I'm the Manager of Strategic Planning for the Maternal, Infant, and Early Childhood Home Visiting Program, or MCV, at the Governor's Office of Early Childhood Development, GOACD. So many letters. But it's my great honor to be with you today as one of the co-facilitators of this session. Our office holds the state's early childhood vision, which is that access to a continuous, equitable, and high-quality early childhood system enables children with the support of their families and communities to grow up safe, healthy, happy, and ready to succeed. Our office works closely in partnership with state agencies, including DCFS, DHS, IDPH, Public Health, and the State Board of Education, as well as the Head Start State Collaboration Office. Kayla, can you introduce yourself as well?
Absolutely, thanks, Joanna. So again, my name is Kayla Goldfarb. I'm with the Ounce of Prevention's Illinois policy team as a policy analyst. My work there primarily focuses on home visiting, and I provide staffing support to the home visiting task force. The Ounce in the early childhood system is very committed to ensuring that all children have the best chance at success in life and school. And the way we go about this is by advocating for and providing the highest quality care and education from the prenatal through this through a multidisciplinary blend of policy, research, programs, and professional development. So I'm delighted to be joining everyone for this workshop today.
All right, thank you. Let's move to slide 3. I know that all of us are thinking deeply about the events of the past few weeks, the killings of George Floyd, Breonna Taylor, and so many others. And I know that we're also thinking about the systemic racism leading to their deaths and the deep inequities that we see in our daily lives and in our work with families. The theme of this year's conference is equity from the start, shifting from intentions to outcomes, and it couldn't be more timely and urgent. As we get started, I wanted to sort of do a check-in, wondering if folks can type into the chat, just one word about how you're thinking or feeling about the theme of equity and our session today, and I'll invite Kayla to read off some of the answers as they come in.
So we're seeing disturbed, urgent, overwhelmed, despair, activated, hopeful, fair, angry, sad, confused, focused, frustrated. These are great. Thank you, everyone.
Yeah, and I think we're all feeling a combination of these emotions and these thoughts and how we can be engaged, what we can do within our agencies and at home to support racial equity. So thank you for being with us during this difficult time, and I hope that the session can help give us some tools for moving forward. I'm going to skip slide 4 and go on to slide 5. We did want to get to know a little bit more about who's on the line today and what sector of the early childhood field you represent. So if you could take a moment just to complete the poll, and if, whether you're home visiting, early care and education, early intervention, from a collaboration or other organization, you can type that in the chat as well.
Okay, so folks are filling out the poll. I'm just going to give them, we have about almost close to 50% that have voted. So I'll just give it a little bit. Okay, so our poll results show that 42% represent the home visiting sector, 27% represent early care and education, 20% represent early childhood community collaboratives, and then we have another 7% and 4% with early intervention.
Okay, great. Thank you. So we have quite a group with us today, and I think we'll have a very good discussion in the chat about the topics we'll be covering. Going to slide 6, our learning objectives for the session are shown here. One is learning more about home visiting services and the role of home visitors. 2, identifying a best practice that could apply to your work. 3, around messaging that you could use about home visiting. And 4, identifying more resources to seek out. And so we have just one last question for you before we get started. Wondering which one of these objectives is of the most interest to you today. So we just want to get a better feel of where your interest lies so we can, shift the timing of the presentation as needed.
Okay, we've gotten close to 40% that have voted. Just going to give folks a little bit of time. Okay, so it looks like we have 2 at 30% from the objectives. So one objective, identify at least one best practice or theme from home visiting, and then the other one also at 30%, identify at least one resource that you could seek out. And then at 23%, start to develop a message that you could use to explain home visiting, and then finally distinguish between the various types of home visiting services.
All right. Well, thank you very much for helping us guide our presentation to be most useful to you. On slide 7, you can see the overview of what we plan to cover, starting with an overview related to early childhood and priority populations, moving towards the home visiting system, the continuum of services, then going into lessons learned and ending with how we've adapted to coronavirus environment and messaging. So just know that we will have a few other polling questions and designated Q&A times throughout the presentation. But if you have questions at any time, please do go ahead and enter those into the chat, and we'll do our best to keep up with those questions. With that, let me turn it over to Kayla for the next section.
Sounds good. Thanks, Joanna. So we will start by, again, diving into priority populations, with the focus being sort of how different populations relate to the access and availability of different early childhood services, and how those different services can be important in addressing key inequities for children and families in our state. So on the importance of early childhood, I realize given the composition of everyone on today's call, a lot of this will be preaching to the choir somewhat. But for the sake of grounding our conversation today, I think it's important to just touch on why addressing disparities in access is so critical during these early years. So we know, of course, that the first 3 years of life represent the most rapid, critical, amazing, but also vulnerable period of development in the entire human lifespan. It's during this time that our brain architecture is really being built up. The foundation is being laid through our early experiences. And these early experiences lay the groundwork for future development to build on the capabilities that we rely on as adults, things like focus, planning, attention, all of those things that get us through the day. And so as we develop, our brains continue to develop over time as well. What we know from emerging research and a wealth of research is really that neuroplasticity is somewhat of a double-edged sword. So as positive experiences can really build, the foundation for later health and well-being and future success, adverse experiences like chronic stress and homelessness and early childhood challenges can leave children vulnerable to poor physical, mental, social, emotional health in early childhood and then later on. So we just want to start here to really emphasize why talking about equity and access and disparities in outcomes is really important in that very early period. So on this slide here, you'll see sort of a continuum of the places in which racial and ethnic disparities can show up across the continuum of development, from the prenatal period through early childhood, and into adolescence. And so given the importance of the first years of life, we really want to name how important it is to understand these disparities so that we can address them, not to attribute them to families or children, but to be able to name the ways in which a lack of access to services and resources can impact the ability of all children to thrive. And so in a little bit here, I'll walk through a couple of different examples, and these are not meant to sort of give a comprehensive view of all of the ways in which we're seeing disparities show up for children and families, but just touch on some of the snapshots as they relate both to priority populations, but then also to sort of the things that home visiting can help support and address. I also did want to talk a little bit, building off of what we heard from our summit hosts about sort of how we conceptualize racial equity in an early childhood system. So we see an early learning system, an early education system as racially equitable when it's driven by data, and it also ensures that every family, regardless of race, ethnicity, social circumstance, neighborhood, has everything that they need to thrive, and that their identity doesn't determine their outcomes. So we see resources, rewards, burdens all being distributed equally across communities and groups, and then also ensuring that those experiencing the greatest challenges are receiving adequate resources and support. And then sort of building up from that policies and systems are designed in a way to promote greater justice for children and families. So on this slide here, what I did want to call out is that the Erickson Institute's Risk and Reach report is a really valuable tool for examining child well-being in relation to state investments. They do this sort of across the board for all of Illinois, but they also really well sort of disaggregate that data into different aspects of race and ethnicity to help us understand essentially how all children are faring. We know that when we look across averages, sort of different pockets can be sort of concealed, and so it's very important to be able to access that data and understand not only the demographic contours of our 0 to 5 population, but also how disparities in access are playing out across key ECE outcomes. So I would encourage everyone to check out this report at a later date. It's online and widely available. On this next slide here, we'll actually start on the bottom, just sort of in terms of a developmental continuum. We see, of course, that children of color and birthing parents of color are less likely to have adequate prenatal care as compared to their white peers. And we know, of course, that prompt and adequate prenatal care, facilitates the detection of a host of, compensations in complications in pregnancy and development. And so as a result, families that don't have access to adequate prenatal care or who begin it later in the pregnancy are at a higher risk of a host of complications, including preterm birth, low birth weight, infant mortality, morbidity, and where that translates to is in sort of future health and development. And so moving up onto that second graph here, we see that disparities in kindergarten readiness are persisting across race and ethnicity. I would call out on this graph here that this is a graph showing the share of children who are showing up not demonstrating kindergarten readiness. And so we again see that children of color are experiencing a lower rate of kindergarten readiness, and we would like to call attention to that as an aspect of home visiting that we think is important in boosting school readiness among children. Moving on here, I think it's tempting to sort of look at a chart like this, which shows the share of children across race and ethnicity under a certain level of the federal poverty level and say, oh, it's all related to income and family income. But we know, of course, that the circumstances are a lot more complicated than that. And while poverty does correlate to a lot of these disparities and outcomes, it's not the only reason. We also know that while the share of children living under the federal poverty level does shift annually depending on the economy and other factors, the share of children of color living under the federal poverty level remains consistently higher than white children. And so the key takeaway here is not, of course, that these outcomes are the result of poor parenting or any inherent family deficiency. It's rather that policies combined with historical inequities that dictate the allocation of resources have disadvantaged families of color in Illinois and across the country. And so what we're seeing in terms of disparate outcomes is really the result of policy failures, failures to make the resources and opportunities as widely available and accessible and responsive to family need to ensure that all children can thrive. So on this next piece here, I did want to call attention to the fact that we're not just observing disparities in outcomes for kids, we're also seeing it in terms of parent well-being. We know, of course, that maternal mortality and morbidity are internationally viewed as indicators by which to judge the health of the entire nation or a community. Overall, in the United States, maternal morbidity is a relatively rare event, thankfully. But while around the world, maternal morbidity and mortality are declining, in the US, they're actually increasing. And we also know that we're home to vast disparities across race and ethnicity. There was a 2018 report by the Department of Public Health here in Illinois that documented these reports and found that non-Hispanic Black women are 6 times more likely to die of a pregnancy-related condition as compared to their non-Hispanic white peers. And we know that this is about as devastating as it can be for families. This is a complete policy failure, and we're seeing just how egregious that is, especially given that many of these pregnancy-related deaths have been found to be preventable. And so when we touch on sort of the continuum of home visiting services later in this presentation, we'd like you to keep in mind sort of the outcomes that we're seeking to address when we expand access to services. We know that from the prenatal period through sort of the early postpartum period, the health and well-being of babies as well as moms is very important. And unfortunately, we're seeing some deep disparities there that require deep attention to be addressed. So moving on here, this long list of populations that you see here is the priority populations recommendation. So the recommendation and the list essentially stem from the Illinois Early Learning Council, which is dedicated to essentially strengthening, coordinating, and expanding programs for children birth to 5 in Illinois. And in 2013, a committee under this Early Learning Council came up with a list of priority populations to essentially dictate where do we need to be devoting more attention and more resources. In 2019, noting sort of what had changed in both the political, economic, sort of social landscape, the group sort of revisited these priority populations to again ensure that we're identifying groups that are being underserved by our current system. Most early care and education programs, as you would know, have systems in place to enroll certain populations and enroll sort of priority populations, but we know that barriers persist in terms of access across everything from home visiting in the prenatal to early childhood phase up to EI and then pre-K. So these are areas in which the priority populations can help us attend to gaps in our resource and policy systems. So the ultimate goal, as we just sort of wrap up this section here, of the priority populations, of that list of groups that you saw, is to drive resources and attention towards improving high quality sort of responsive services for families. We know that we can't begin to address some of the outcomes we're observing across race and ethnicity if we're not attentive to the gaps in services. So having sort of examined some of these persistent disparities, we'd like to then have you call to mind the ways in which your own work has you interacting with priority populations. So at any point, if you want to share in the chat sort of how your work connects you to different priority populations, I think we'd all like to see sort of what your experience level is and sort of how you've brought that into your work. There are some additional resources here that you can access in the materials. And with that, I'll pass it off to Joanna for our next section, which is an overview of the home visiting system.
Okay, thank you, Kayla. Going to slide 18, when we talk about the early childhood system, again, we're referring to a collection of interrelated parts that's shown in this diagram, is graphic from the National Early Childhood Systems Working Group. You can see early learning, family supports, that includes economic and parenting supports, health, mental health and nutrition, and special needs and early intervention. And the reason why that oval is sort of in the dotted line is because it relates to a subset of families, not necessarily all families. And so looking at this, I would say that home visiting touches on each of these ovals and actually helps to strengthen the connections between them. And so as we dive further into home visiting, I hope you'll keep these domains in mind as important levers for healthy child development. On slide 19, this is just along the early childhood developmental trajectory. Home visiting really covers the entire range from prenatal to age 5. Slide 20. And so what is home visiting? We have some knowledgeable people already. We have home visitors online, I'm sure, who can say this better than I can. But we like to say that home visiting is family support and parenting coaching by a trained professional through planned regular visits at the home, prenatally again through the child's early years. And so home visiting is an evidence-based prevention strategy used to support pregnant and parenting and new parents, to promote infant and child health, foster educational development, school readiness, and help prevent child abuse and neglect. Participation in home visiting is voluntary and it's free. Home visitors might be trained nurses, social workers, or child development specialists, and the visits focus on promoting strong parent-child attachment and coaching parents on learning activities that foster their child development. Research has shown that home visiting programs increase children's literacy and high school graduation rates, as well as how much parents read to their children. Home visiting programs also increase positive birth outcomes, improve the likelihood that families have a primary care physician, and decrease rates of child abuse and neglect. On slide 21, we had originally included a video so that you can see a brief sample visit. In the interest of time, we'll let you explore that on your own on YouTube. But certainly this gives those of you who aren't already in the field to give a nice picture of what happens and the important role that home visitors play. Slide 22. In terms of the home visiting system, we have a wonderful active group of stakeholders in the home visiting task force. The state has a big tent approach to home visiting, a network of over 375 programs and at least 7 home visiting models. The ALICE is the centralized provider of professional development for most of the models, and the important role of infant and early childhood mental health consultation just can't be stated enough. Going on to slide 23, this messy picture shows the combination of state and federal funding, as well as private dollars that go into the home visiting system. And so it is messy. You can see many layers. And that's one of the challenges that the state's Early Childhood Funding Commission is grappling with right now to figure out how do we rethink and reorganize our early childhood system, including but not limited to home visiting. We're fortunate in Illinois that our office has been working very closely with the other funders listed here for many years since before the McBee program started, to do whatever our best to collaborate. Most recently, we've put out a joint guidance related to the phases of Restore Illinois in relation to the COVID-19 pandemic, and we're very much indebted to all of the funders for being able to work together so closely. In the next slide, slide 24, just gives you a picture of the total funding for home visiting in fiscal year 18, with you can see that the lion's share comes from ISB, Illinois State Board of Education Prevention Initiative, as well as from Early Head Start and Head Start. On slide 25, in fiscal year 18, again, over 19,000 children received home visiting services in Illinois, and about 1/3 were Black, 1/3 were Latinx, and 1/3 were white. Again, this looks at the major home visiting models that we have, again, with the bulk of the programs using the parents as teachers model, PAT, or Early Head Start, followed by Healthy Families America. We'll be talking more about the different models shortly. Going to slide 26. In many communities, we have multiple home visiting models funded by multiple funding streams. So a coordinated approach is really needed to help families navigate the system and to avoid duplication, as well as to help ensure that we're effectively reaching families from the priority populations. Coordinated intake is designed to provide a streamlined point of entry that connects many partner agencies, such as healthcare providers, schools, WIC programs, social service agencies, with a home visiting program that can best meet the family's needs and choice. Slide 27. All I want to say about this is that there are a couple of coordinated intake projects that go through our office. One is McBee Coordinated Intake, in which we're currently providing coordinated intake in 12 communities. And you can go to the igrowillinois.org website for a list of those contact folks in the communities. The second one listed here is a regional coordinated intake pilot that's happening through the Preschool Development Grant, Birth to 5 grant. In this pilot, 5 multi-county regions will be selected this fall through a letter of intent process, and we're working closely with DHS and the Illinois Head Start Association on that. So please expect more information by July 1st. The next slide, slide 28, sort of wraps up. To summarize, the system is complex. We know that navigation is very difficult for families as well as for other providers who are trying to make referrals to home visiting. And so we had a couple of questions here for you in the chat, but knowing how many of you are already involved in home visiting, I'm going to switch it up a little and to say how connected, if you're in home visiting, how connected are you to your local early childhood collaborative? And then if you are not in home visiting, maybe how connected you feel to home visiting programs in your area.
So again, for folks who didn't maybe hear Joanna, we'd love to see in the chat, if you're part of home visiting, how connected do you feel to your local early childhood collab? And if home visiting is not your profession, how connected do you feel to the home visiting agencies, providers in your community? We'd love to see that in the chat. Seeing a "we are working on it," I think that's a great response. Having quarterly collab meetings where I can call in and talk whenever an issue arises. I'm assuming that's from someone who's a home visitor, well connected. So that's fantastic.
All right, it's good to know that the connections are being made. We know that it's not always easy to connect from one sector to another, and so we appreciate everyone that's working hard to bridge those connections. With that, back to Taylor.
Sounds good, and I appreciate that everyone is still continuing to add their thoughts in the chat. It looks like folks are remarkably well connected, and so I commend you all on that. As Joanna mentioned, the system is really complicated, and so we applaud you for doing that work, and hopefully we can try to help decipher any information barriers as they arise. Moving on to the next section here, we're going to touch on the continuum of home visiting services. And before we get into that sort of framework, again, back to another poll, we'd like to ask you, for those who are home visitors as well as those from other early childhood sectors, how familiar are you with services outside of core intensive home visiting that fall under the home visiting umbrella in Illinois? So we're going to launch a poll and get your responses to that.
Okay, just a few more seconds.
So we're seeing a "I don't understand the question." And I guess we could rephrase that by like, have you ever heard of any other services outside of sort of basic home visiting that are under the home visiting umbrella? Does the idea of a continuum of home visiting seem familiar to you or totally out of the blue?
Okay, and so we have somewhat familiar with 56% saying that, and then 23% very familiar, and then 21% not familiar at all.
Wonderful. Thank you for reading those out. That, I think, makes perfect sense given the sort of attendees we have on the call today. I know a number of you are home visiting professionals or are in that work, but then others work very closely, it sounds like, through early childhood collabs in your community or other connection points. So we'll try to sort of demystify this framework. It's really sort of our own way of making the system perhaps even more complicated. So I shouldn't have put a gotcha question up there. But moving on to this next slide here, which is sort of our diagram on the continuum of home visiting services. We've put this up here to sort of represent sort of the range of services that can span from the prenatal through age 5 period, and can involve anything from sort of a lighter touch universal support of someone visiting a family at the home, all the way up to sort of more high intensity, precision based services that meet the individual needs of families, perhaps those with more complex needs. And so in the next section, we'll sort of go through in a little bit more detail what these different services look like along the continuum. But just generally speaking, wanted to lay that framework out for you to bear in mind as we move through the next sections of our presentation. I will say for those who sort of would prefer to conceptualize this in terms of programs that you might be familiar with, at the bottom along that purple arrow there, we would think of Family Connects, a universal newborn supports program, as something sort of more lighter touch that can be available to all families. And then, as we'll get into later in the other sections, particular interventions designed to meet the needs of priority populations would fall under that high intensity framework. And then, of course, these all span sort of different touch points along the developmental continuum. So moving on here, we have a table set up to sort of demonstrate both the age of enrollment eligibility as well as the age through which services can continue for different home visiting interventions. For some models, as you'll see here, there isn't a purple line designating where enrollment can end, but for some, like nurse-family partnership, enrollment has to happen before 28 weeks. So pregnant parent would have to enroll before 28 weeks. So we've sort of tried to designate that there with a purple line, trying to make it as clear as possible when the cutoff is for enrollment. Almost all of the models in Illinois can enroll prenatally, and we really do strongly encourage this. Data shows that when families engage prenatally, they're more likely to stay in home visiting longer, and we see greater outcomes too when we enroll families prenatally. Family Connects, as we'll talk about, is a unique approach that you're seeing in that very short window right after birth. HIPPY and Head Start can enroll from ages 3 to 5. And then in terms of how long these models are lasting, again, it differs from the eligibility windows. Doulas, again, can only sort of continue into that perinatal period, but then they would make the handoff to a home visitor in many cases. But most models, again, we're seeing are serving children through ages 3 to 5, depending on sort of what they're set up to do. What this, essentially shows is that the system is diverse. We have a sort of mixed delivery system for home visiting models, and they're all sort of hopefully set up in a way that a family could receive sort of different touch points of support at different periods. We know that the full range is not available to every community, and certainly some counties don't have any home visiting programs. And so when we talk about expanding access, in particular to priority populations, but growing home visiting more widely, we're trying to understand sort of where these gaps in services are, both locally and then along this continuum. Moving on to this slide here, so I wanted to touch briefly on what Family Connects sort of is and means along this continuum. We know, of course, that the first few weeks of parenting are incredibly difficult for any family, whether you're a priority population with perhaps more complex needs or just any family, because babies don't come with instruction manuals, and those first few weeks involve sort of overlapping demands on new parents. And so Family Connects sort of emerged because, nationally and in Illinois, there's no comprehensive standard universal system to support newborns and their families all at once. And so the model essentially emerged from Duke and is really based on that principle that all families can benefit from some form of support in welcoming a new baby. So Family Connects is an evidence-based model that we see under the umbrella of home visiting, but it doesn't meet what we would call sort of traditional home visiting. It's not, as Joanna mentioned, a regular ongoing visit for 90 minutes focusing on child development, facilitated parent-child interactions. It's a sort of one-time touch wherein the nurse will connect with the family immediately after labor and delivery, do sort of an at-home check-in, doing a physical assessment of mom and baby, and then depending on the needs that they assess, connect that family out to the appropriate community resources. So again, we want to sort of emphasize that while this is under the umbrella of home visiting, it's not what we would consider core intensive home visiting services. So along that continuum, it may serve more families were we to expand it as widely as sort of a statewide reach. but would not give them the depth of sort of contact that our traditional home visiting services would. Moving on just to some of the evidence base, as Family Connects might not be as familiar to all. The robust research coming out of both sort of Durham, where the model originated nationally, as well as our own Illinois research, shows that we see strong positive outcomes in terms of reductions in child welfare investigations, the need for families to utilize emergency medical care early in infancy. We see parents feeling less anxious and self-reporting, that they feel sort of more confident in their parenting skills. And then we also know that families are more connected to community resources. So in many ways, the goals and the outcomes of Family Connects mirror those of traditional home visiting, but are delivered in a very different way. And I did want to pull up this quote here because I think it's great to just show what's so particularly special about Family Connects and how it differs from other home visiting services and frankly other early childhood services. So this is a quote from the formative evaluation of the program as it was done in Illinois. And essentially we're seeing that because the program is universal, we're catching families across a range of risk. We know that it's really hard to understand what makes a family at risk for certain sort of poor outcomes in early childhood. And by having this wide net, we can support all families broadly, and then also not assign some of the stigma that may accompany more targeted services. We know that sometimes families can feel that they're being particularly named or called out as at risk, and that can feel very negative for families. So again, given how many home visitors are actually on the call and who could do this part so much more justice than I could as someone who's not a home visitor, we would just call out again sort of that core intensive home visiting services are really the ones serving families the most in Illinois. So when we look at that sort of 20,000 number that we serve roughly every year, most of them are receiving services that look like this. So these 90-minute visits, these sort of deep engagements between parent and child, it's a very relational service, and involves things like developmental screenings, but then also referrals back out to community resources. One thing I did want to make sure we spent a little bit of time on is the doula model, because again, this is not something that is embedded within every home visiting program. But doulas are, like home visitors, trained community-based paraprofessionals, but they work primarily sort of prenatally to support the connection between parent and child before the child is even born, and then also to help advocate for the birthing person to ensure better birth outcomes. We know that doulas, when they support parents prenatally, we see sort of improvements in satisfaction, healthier births, healthier babies, essentially, and they help to ensure that families feel supported and listened to. Calling back to some of the facts we read on maternal mortality, we know that some of the disparities we see are because the medical system doesn't listen to all birthing parents in the way that it should. And so doulas can help be sort of a voice, an advocate within the labor and delivery room to ensure that birthing parents are supported and that their medical needs are taken very seriously. This slide here is just a flag of what's to come, which is a deeper dive into some of the priority populations. These populations on the left here are sort of the populations as you find them in the priority populations recommendation. And then the innovative projects on the right are sort of the ways in which our home visiting system has worked to try to meet the particular needs of these families. Again, referring back to that continuum, we would see this at the very top as sort of the most in-depth interventions that are reaching the fewest families, but sort of meeting the particular needs presented by their circumstances. So we see homeless families, child welfare involved families, pregnant and parenting teens who differ from older parents, as well as we have another project that we won't get into today that touches on parents in the Cook County jail system. So with that, I'll pass it over. Oh, I'm sorry, we have one more slide here on summary before I pass it back to Joanna. Just wanted to again call attention to the range of services that we see in Illinois. So when we communicate about home visiting, it's not sort of a one size fits all. We know, of course, that these are not widely available to everyone, but we'd like to grow access in a way that makes sure that all priority populations and indeed all families can receive the support they need. So with that, I will pass it off to Joanna to do some of that deep dive into these projects and the way they serve priority populations.
Okay, great. Thank you, Kayla. And I will be doing an introduction to several of our projects, as Kayla mentioned. But in the time that we have, it's kind of a whirlwind tour approach, and I know I won't be able to do justice to all of the good work that our partners have been doing. So moving to slide 41, we know obviously that that homelessness inequitably affects Black families in Illinois. You can see this from the risk and reach graphic that's at the bottom of the slide. We also know that homelessness is linked to lower birth weights, higher rates of emotional and behavioral concerns in children, higher rates of developmental delays, and a number of other outcomes. And so that's why this project was developed, to try to unite kind of two service universes together, the home visiting world and the homelessness services world, to see how we can improve the trajectories for families. And so this project is being led by the Ounce of Prevention under Shawanda Jennings and Carrie Byers, among others, and supported in part by McPhee Dollars. And there are actually three approaches that the project is taking. One is where there's a home visitor with part of their caseload dedicated to families who are experiencing homelessness. Another approach where a program may have designated one full-time home visitor for all of their caseload to be with families experiencing homelessness. And then the third, a model where the home visiting program is actually based and embedded in the shelter. And in all cases, the visits are actually in the shelter. So the project is in the process of developing an evaluation, but meanwhile, it wanted to share some of the highlights that are coming out of their work. On slide 42, there are some of the successful strategies around engagement and service delivery are highlighted here. And in terms of engagement, that our home visiting partners found a number of good strategies using mobile apps such as WhatsApp.
Kayla, I think we just lost Joanna.
I'm sorry, can you hear her now?
I can hear you. Yeah, now I can hear Joanna, yes.
Okay, I'm sorry about that. So I don't know when I dropped off, but I was highlighting some of the engagement strategies that have been successful in this project. So using mobile apps, keeping the appointments on the behalf of the visitor, even if you're not quite sure if the family's going to be there or haven't been able to check in. Being able to leave the home visitor's business card or other contact information at all of the known residences and with other family members, so that there's multiple ways of connecting with the home visitor. Leaving door hangers, if you've missed somebody and they're not there. And in terms of service delivery, I think the most important recommendation that has come out is just to be very understanding of the trauma that families have experienced. Being willing to follow families if they are mobile families, right, when they move to the best of your ability. Individualize the work with families, understand that there are going to be kind of urgent needs that arise, and being able to balance that case management or support for crisis intervention along with the parent-child interaction that is the focus of the home visiting curriculum, and always being positive and encouraging and supporting the family where they are. Moving to slide 43. Some of the things that made it work were, as challenges that are listed here are not surprising to you, I'm sure. Complexity of needs, the kind of challenging to develop engagement. There was a call for additional trainings. For example, home visiting programs want to know more about the homeless provider system and housing resources. And in fact, the House is developing a toolkit on this that should be released this summer. The need for more trauma-informed training, mental health first aid, self-care training, fan training that's facilitated attuned interactions. Training, and these are being developed through or offered through the ALS, as well as through, again, the invaluable role of the infant mental health consultants. And so I know that was kind of a whirlwind tour through this program. I'd like to pause a little. I'm sure people are having trouble hearing me as well, so I apologize. But just wondering if you can share in the chat, what are some takeaways for you, or what resonates with you as you're thinking about this project? Or what would you like to know more about?
So again, just knowing we have audio issues, we'd love to hear what stands out to you in terms of the key takeaways from this project, anything that comes to mind when you think about how you serve populations experiencing homelessness. We're seeing a question, how did you get the flexibility to do this? And so that's a great call out from sort of a more program mechanics piece in terms of the model flexibility and the model permissions. We've got someone speaking to serving children at shelters, which I know has presented challenges to this project, but to others as well.
Right, absolutely. I think a whole hour and a half workshop could probably be developed on this alone. But in terms of I can speak to a little bit the question about flexibility. I mean, for McVie, we're fortunate that our federal funder is very much focused on priority population and is interested in being innovative and be able to figure out how we can be more effective in the field. And so we've also enjoyed a close relationship with the home visiting models. There's a national consortium of models that we work with. And so I think we've been able to have those conversations with folks, knowing that we all have the same end goal in mind. And so where is the flexibility? How can we learn from these small scale projects and hopefully scale up in the future? So I hope I've at least addressed a little bit of that question.
Thank you, Joanna. So folks, feel free to add additional questions in the chat, and we'll try to address those as they come up.
I'm going to keep going to the next project. So this is the Illinois Pregnant and Parenting Youth and Care Home Visiting Project. Many words there, so we shorten it to IPIC. This is, again, another underserved population by home visiting, even though we know that research shows higher risk among children who are born to youth in care. And so this project was also designed by the Home Visiting Task Force. They established a child welfare self-committee back in 2015. And the project is also supported by McVie funds, several funds, led by Children's Home and Aid. We provide some, guidance and troubleshooting. The project also works with the Teen Parenting Services Network, TPSN, which was already in place as the kind of a hub for youth in care. And then Chapin Hall serves as the project evaluator. You can see here that 61 youth were referred during that pilot evaluation period of 2016 to 2018. Going to the next slide. These are actually some of the barriers that were identified, as you can imagine, right? Confusion over mechanics of the child welfare system. Again, this is similar to what was expressed in the homelessness project. That home visiting, we are each in our own little worlds, right? In this case, home visiting wants more about child welfare. In the other case, building closer connections to homelessness service providers. So again, trauma-informed practice, this is another carryover. Same barrier or need was identified in the Homelessness Project 2. How can home visitors feel better equipped and using a trauma-informed approach? In this project, there were some barriers around serving clients in congregate group care facilities. Sometimes a home visitor would not be allowed in to the facility, or there were other activities that were planned at the same time as the visit, and then the visit had to be cut short. So communication issues that emerged at the outset of this project that we learned from. And then because of all of these extra layers, finding that working with child welfare involved parenting, pregnant parenting, youth, and care requires additional time, requires additional resources. And so then going back again to having that, how can we build in that flexibility? So around caseload, around other expectations. Next slide, slide 46. So what makes it work? The evaluation team at Chapin Hall pulled out some of these factors, the strategies that made the project successful. They were finding that, not surprising to all of you who are home visitors, that home visitors in this project, as always, are going above and beyond kind of the curriculum and what the model might be focused on in order to meet clients where they are, meeting the client's needs. Again, similar to working with the homeless families, being able to shift to the crisis of the moment, and there were many crises in these young people's lives, as you can imagine. Building knowledge across the systems, doing cross trainings, bringing people from different sectors, child welfare and home visiting, in closer connection with each other. Again, the importance of mental health consultation, the SAN, and flexibility and how we're able to keep the family engaged. And so Chapin Hall developed a evaluation report for this project, which is one of the resources that will direct you to toward the end of this section. Finally, on page 47, I won't go into these, but as a result of what was learned in the pilot, Healthy Families America, the model for home visiting, developed a child welfare adaptation that took many of these possibilities into consideration. So we really think that's a successful partnership with the national model, working with the locals to figure out what works and how to scale that up. Another result of the pilot that isn't on this slide is that DCFS has taken the framework of this pilot and is adapting it to use with intact families who are pregnant or parenting an infant up to age 6 months. And so there is now a full-time home visiting specialist at the DCFS Erickson Early Childhood Project who is connecting these priority families to home visiting. And DCFS is planning to scale this up to have a team of home visiting specialists that will cover the entire state. And here, as in the last project, Chapin Hall is going to lead a continuous quality improvement process to support this work. We're very excited to see the scale up moving forward. And so let me pause again and give you an opportunity to share feedback in the chat. Again, what resonates? What are the takeaways that you see? What are the questions that you have?
So again, knowing we might have some audio issues, if there are remaining questions about this collaboration between home visiting and child welfare, concerns, reflections on what you might take into your own practice, we'd love to see those in the chat. I do want to spend 1 second to address a comment that was raised earlier about the sort of challenges presented between collaborating between EI and home visiting. We know that this is the collaboration issues and the sort of issues in working cross silo aren't sort of exclusive to child welfare. And so one of the resources I hope to plop in the chat when I can figure out how to do that without ending the screen share is a suite of resources developed from the Serving Families Together initiative, which involve a cross training between early intervention, home visiting, and child welfare. So we have a link to one of those slides in our summary here, but for those who are calling that out, certainly there's a need for greater collaboration, and Also documentation of some of the barriers that exist for practitioners. So hearing thank you that, there are difficulties is important. In the chat, we're seeing there are collaborations with our local DCFS department. We do not get any referrals to them, or from them, excuse me.
Right, and I'm thinking that maybe that is from a home visiting program. And if that's the case, I mean, one of the roles of these home visiting specialists that are housed at DCFS Erickson is that there will be a home visiting specialist assigned to every region of a DCFS region of the state, and so that person can help you be kind of that connector or provide that linkage between home visiting and between child welfare and home visiting and other services that maybe haven't been as strong in the past. So we appreciate that.
Mm-hmm. Other things in the chat that we're seeing, so someone has called out that they've worked with families whose children who have been removed from the home while in Indiana, and it was helpful because families were receptive about what they needed and wanted to do. And so again, calling out the unique role that home visiting can play in supporting families in reunification or in supporting a healthy parent-child relationship even when the parent has been removed. And so again, that's what you're seeing at the top there, remaining involved with families even if the child is removed, as long as reunification is the goal there. So again, thank you for calling that out, a wonderful piece of the practice. A question here about if there's a way to let us know who these people are. So I'm assuming that would be on the DCFS specialists, and we can try to follow up with that information in terms of how to connect to those different regional DCFS home visiting folks. We can get some follow up on that. Thank you for flagging that.
Yes, absolutely, we can do that. And Tia Staggers is the one person that is there in place right now, and they're in the process of hiring, filling the additional positions. So we're happy to get her contact information out to you. We're in the process of kind of developing a little a piece that we can share out widely. So thank you for that. Okay. I'm going to continue. Really appreciate the questions as well as the great examples of the work that's already going on, partnerships between child welfare. And so as I wrap up the section on innovative projects, there are a couple of coordinated intake programs based in hospitals that I'd like to introduce. And both of them have worked closely with McVie and planning, and we continue to support their work, not with funding, but with technical assistance, kind of brainstorming and troubleshooting and building connections as needed. So on slide 48, this is the Connect Team project located at Lurie Children's Hospital in Chicago. And the information I'm sharing is from Caitlin Chandler, who leads this work at Lurie's. And the motivation for this program was to improve outcomes specifically for teen parents and their children. And through this project, any referring entity, whether it's schools, social service programs, et cetera, healthcare, can refer teen parents in Chicago to contact the coordinated intake office at Lurie's to be connected to home visiting, doulas, and other programs. In terms of what this makes this project work, there are two strategies that the folks at Lurie's want to share. One is kind of the breadth of their partnerships. Their partnership with Chicago Public Schools has really flourished and helped to elevate their visibility, and so far they've connected with over 50 schools. And also, they've been able to build on their existing partnerships with other hospitals and prenatal clinics, and those have become their largest referral source, actually. Another thing that they found successful is they're bringing together all of the programs that they partner with through their Connect Team Collaborative. This is a space for programs to come together, problem solve, share successes, and share resources. And since the pandemic, they've added monthly phone calls that they're calling Connect Team groups. And one of the recommendations they wanted to share is just being very open to unexpected partnership opportunities. And they said some of their best partnerships were actually unplanned. And so they're being able to keep an open mind and being creative about exploring partnerships they felt was a key to their success. In slide 49 is the last program I'll be talking about today. Rush University Medical Center has an initiative to screen pregnant and postpartum women for ACEs, or adverse childhood experiences, within some of their clinical settings. And so in this project, the pregnant and postpartum women with an ACE score of 3 or higher are linked through their coordinated intake office to an existing home visiting program within the communities that they serve. And you see a map here of the communities, mostly on the west side, a few of the suburbs and near suburbs as well. And so this project is led by Dr. Gina Lowell. She's the Director of Community Health for the Pediatric Department for Rush, along with Jessica Jerichos. She's a women's health nurse practitioner. And here, maybe the unique factor is that their lead patient navigator, Greta Arazo, she's already providing care coordination, and so they built onto her existing position to specifically serve as a coordinated intake for this project. And so they wanted to share a couple of successes. One, they've had good success using the NowPow web-based platform. They're doing that now with 4 of the home visiting programs that they're working with. And this is a web-based system for closing the referral loop. However, they said that they're actually the best way that they're able to track referrals, and it comes through their monthly phone calls with the home visiting providers. And again, so both of these projects, they're having regular contacts with their home visiting partners to share information, get updates, troubleshoot, track progress. And so, again, that speaks to the important role of collaborations, working across sectors to share information for the benefit of families. I'm going to go straight to this last slide here, number 50. And these are some of the resources. As Kayla mentioned, I mentioned a few of them before. More information about the SAN, cross trainings. This one is for home visiting and child welfare, but there are others on the Serving Families Together initiative. The IPIC evaluation, as well as more information about mental health consultation. And so, whether it's a lingering thought that you have from coordinated intake specifically about these 2 projects, or about the homelessness project and child welfare, as you think about whether there are some best practices or lessons that might apply to your work, what are some of the challenges that you're foreseeing, and what kinds of additional support from the field do you think you would need? And this is directly helpful to us, as we're, our office works with many of these projects very closely. It helps us be able to design what these tools could be, and think about how we can get these out to the field in a useful way.
So again, just to echo Joanna, we'd love to hear your thoughts on what resonates, what resources you think are lacking that would allow you to engage with priority populations in some of the ways that these projects have, challenges you'd foresee, or perhaps ways you're collaborating that we have, yet to capture that are super important for the field to know about.
And if there aren't too many questions emerging, or if we want to hold those, we can move back to you, Kayla.
Sounds good, yeah.
At your discretion.
Yeah, we can let folks chime in, and we can always go back to this later. We're seeing folks call out the need for projects around ACEs to be expanded. It's certainly a brilliant model, but to see that expanded into other communities. Seeing an issue is a primary issue being housing authorities. It's a struggle to get families into it and help with homelessness. And then when they get in, they aren't well treated. And so to that, I would say I certainly don't have an answer. I know that's a complex issue. I think something that's been helpful for the partners involved in the homeless families project has been forming sort of continual relationships with folks within the housing world. As Joanna mentioned, in part of the 3 approaches that serve these families, you have families being served in shelters, families being served in other sort of housing locations, and so forming partnerships and ongoing check-ins with those housing services providers has very much supported the work. We've got Carol calling out that the FAN is critical in helping both home visitor retention and also finding the joy in the work. Would encourage folks to check out that linked resource. So seeing not too many remaining questions, we will move on, but please do let us know in the chat how you would sort of bring this into your work. Okay, so our last little section here I think is needed because when we thought about this presentation, it was before the pandemic, and now services and the service landscape for home visiting has changed pretty dramatically. Beginning sort of mid-March, services for home visiting as well as doula coordinated intake have all been exclusively virtual as we work to support families through no contact contacts and essentially ensure that the system responds to family needs without actually sort of increasing their risk to COVID. That being said, as we look along the top here, we see that the Governor's Restore Illinois plan has us sort of reopening in various phases, and the field wants to make sure that we are ready to do that. And so our recommendation sort of most broadly is that until phase 5, we're not going to see sort of anything resembling a return to normal for home visiting. Beginning in phase 4, we might see some families receiving very brief contacts that we wouldn't count as full visits, but are really just there to check in on and offer added support to the families we know we need to be seeing briefly in person. Maybe that's dropping off materials, or maybe it's for families who might need sort of added support because privacy doesn't allow them to do a virtual visit to touch on certain difficult topics within the homes, and they need to get a referral from their home visitor. We have sort of information that's changing pretty rapidly here as both we move through these phases of reopening and we sort of evaluate the needs of families. So I would encourage folks to use this link in the embedded slide deck to access GOECD's Provider Hub, which provides the latest info on where home visiting is at, but also sort of the other early childhood systems and how they can connect to various resources here. Moving on to this next slide, because the service landscape has changed so much, it's presented challenges to providers in connecting to families, both those who were prior engaged in home visiting and then those that we'd like to enroll and connect for the first time. So we are developing some messaging around what role home visiting can play for families, and would love, given the wide range of expertise on this call, to sort of use you all as a small focus group and hear your input on what really stands out in messaging the benefits of home visiting sort of for all families and for priority populations that we could use to sort of augment our outreach and make sure that we're reaching families in a way that feels appropriate. So what you see on the screen here is some sort of quick overview of what we're using to talk to families, mentioning that you don't have to do this alone. Parenting during the pandemic is difficult and brings new stresses, but home visiting is there for you. And then also calling out just sort of the mechanics that a home visit might involve. And so I'll pause here because we're seeing some chatter in the chat box. We see someone describing the home visitors as a family's cheerleader is really important. So I love that. I think that's a great addition and a way we can sort of connect with families and feel like we're speaking in a language that entices home visiting, makes the services seem supportive during this time, which we know is so stressful. Moving on, and again, I would just call out if you have any thoughts additionally as we go on about how we should be talking to families, we would encourage you to add those into the chat. This next slide sort of summarizes how we're talking to other referral systems. And so this is maybe applicable to folks who mentioned at the start of our presentation that you're not a home visitor, you're coming from the EI world, you're a mental health consultant, but you sort of engage with home visiting. We want to message to those providers and those referral sources that home visiting is really essential and that we're dependent on our network of ECE providers to connect families and enroll them in eligible slots. So again, calling out the activities as you'll see below, like developmental screening, connections to community referrals, reducing parent isolation, screening for depression and intimate partner violence, sort of the things that home visitors can do. And then finally, calling out the mechanics of how that might happen in a pandemic, a sort of unprecedented environment, so that folks can go to a centralized hub of information at the iGrow website. Where available, they can contact their local coordinated intake program and just sort of call up that coordinated intake worker to make the connection for them. Or if all else fails, recognizing that the system is really complicated, they can give a centralized number a call or email us, and we'll try to route your questions appropriately. So having sort of flown by that as we near the end of our session here, I would again sort of ask if folks are thinking through this and processing both the messaging for parents, families, and for providers. What stands out? Does this seem like the appropriate tone to be setting with families? Do you feel like there are different benefits that stand out to you when you think about home visiting that we're missing the boat to describe here? And if folks are thinking about that in the chat box, we will move on. So knowing where we're at, as we've described, sort of our virtual system, and that we have programs that are still doing enrollment, and that we're putting out messaging to encourage folks to enroll, we wanted to ask, sort of having seen the system in its complexities, how comfortable do you feel referring a family to home visiting? So we're going to pop up a poll here, and this will give us sort of a live reading on whether we have a lot more work to do in making referrals clear to the ECE community. Also seeing a question, will slides be shared after the presentation? So those should be available. Yes, thank you. Materials available on the spot for download under the materials tab on your training portal.
And we have about half of the folks that have voted. So I'm gonna just give maybe like 5 more seconds, and then I'm gonna go ahead and close it out.
Thank you.
Okay. So we have most people have said they feel comfortable referring a family to home visiting with 71%, 26% saying they're somewhat comfortable, and 3% saying they're not comfortable at all.
Okay, thank you for reading that. So in the remaining time, I think we'd like to then, turn it over to, again, reflections on what works for you in this messaging, but then also for the folks who said they're somewhat comfortable or not comfortable at all, we'd like to open it up to sort of a Q&A discussion on what other resources you might need, what feels confusing, and we can maybe try to talk through that a bit. Joanna, for your reference, we are on the Q&A slide now. So we have a question in the chat. Is the iGrow website only listing programs that have coordinated intake? So the iGrow website should allow you to find a wide variety of programs, not just in coordinated intake communities, but we'll also pull up a contact list on that page in which you can see the specific zip codes that have access to coordinated intake workers. So it's not just coordinated intake communities that are linked on iGrow. Thank you for that question. And so if we're not seeing a ton of questions pop up with respect to mechanics of referrals, would invite folks to weigh in and let us know sort of if there are pieces about serving priority populations that you think will be beneficial to your work, or conversely, if there are pieces of your work and experience that you think should be shared with the group about how to better meet the needs of families who meet priority populations. Our contact info is also up here and then available on those slides for download. So if you want to reach out on any of these issues, we'll be able to get you a fully detailed response via email too.
Great. Thank you so much, Joanna and Kayla. Round of applause, virtual applause for you all. Thank you so much for all that rich information. Just as a reminder that you will receive a follow-up email and you will have all the materials as well as an evaluation link. The evaluation link will also be available in the chat for you to fill out. As an added incentive, when you complete the evaluation, you'll be entered into a drawing to a raffle to win a book, our keynote speaker's book. So you want to talk about race, Ijeoma Oluwa, who's the New York Times bestseller and also our keynote speaker on Thursday. So the more evaluations you complete, the higher your chances are of winning a book. And then we still do have slots actually for our keynote speaker on Thursday. We do still have some openings there, and then also for our closing plenary on Friday. So if you are interested, please go ahead at our website, partnerplanact.org, and you can go ahead and register for those remaining sessions. So we hope you have a great afternoon, and we look forward to to having you back on our other sessions. Thank you, everyone. Have a great afternoon.
Thanks all.
Thanks, Kayla.